Hi, everyone. Thank you so much for coming, taking the time, out of your busy lives and days. But hopefully you learned something today as well. But we really appreciate your support. So, I'm Julia Kenniston, and I'm going to talk about the Viking disease, or what we also call Dupuytren's contracture. So this is just my background. So my college degree was from University of Chicago. I have a master's from Northwestern. My medical degree is from Tufts. My orthopedic residency was at Penn, and then my hand fellowship was at Brown. So I joined Plymouth Bay Orthopedics in 2011. I'm board certified in orthopedics as well as hand surgery, and I just finished my term as president of the medical staff in the hospital. But on to the talk. So what I'm going to talk about is Viking disease, everything you ever wanted to know in the next 10 to 15 minutes. So first, what is it? Who's affected? How to diagnose it and how to treat it. So Viking disease, basically it's this progressive fibrosis of the fascia in the hand. So what that means is directly under the skin is a layer of soft tissue called fascia. And so when that starts clumping together and then causing kind of these bumps and fibrosis along that fascia, that's really what Dupuytren's is. It's a chronic progressive problem. It's also painless. So if you ever develop pain in your hands and you have these bumps, it's not because of the Dupuytren's. There's probably something else going on. But what can happen is as it progresses, it starts causing the fingers to start bending down. And then when that happens, it's a fixed contracture. So it's not something where you can straighten it back out afterwards. It's really a fixed contracture. It's called Dupuytren's because Guillaume Dupuytren was the first person to both do surgery for it as well as actually publish on it. But he's not actually the first person to describe it. So why is it called Viking disease? So initially it was called Viking disease because they found that it was seen mostly in people of Scandinavian descent. And then they noticed it was in people of Northern Europe. And they thought this is because the Vikings came and invaded all of Northern Europe. In 865, they came into England. So in Scotland, they called it the Curse of the Macrimans, where the fingers bent down and they weren't able to play the bagpipes. But it's actually misnamed. So in 2002, there was a study looking at the prevalence of Dupuytren's. And in this small population, so if you notice the number of men, the numbers are relatively small. But what they found was that in Norway, there was a high prevalence, 46, and in Scotland of 39. But in a more recent study, so in 2020, they did a meta-analysis with much larger numbers, and they actually found that the prevalence was higher in Asia, mostly Japan, compared to Europe. So overall, what they agree upon really is that the prevalence is approximately 8%. There's a big genetic component to it, but it's not a directly, if your parents have it, you're definitely gonna get it. It's more of a, if you had a big family reunion, someone else has it. Men are more affected than women, and it's also associated with these other listed factors here. So who has Dupuytren's? You do, or your neighbor does. In this area, I see it all the time. So someone that you know here probably has Dupuytren's in their palm. Other famous people listed here. Ronald Reagan, interestingly, had Dupuytren's, and he had surgery for it when he was president. Bill Nighy is an English actor. He's in kind of the bottom right or your left-hand side. So he has pretty significant Dupuytren's that he doesn't have treated. So you can see it in his fingers in that picture there. John Elway, former quarterback for the Denver Broncos, also had Dupuytren's and is now as a spokesman for one of the treatments for Dupuytren's. So how do we diagnose it? Really, it's a physical exam. So it's history and physical exam. There's no imaging study to really look at this. So it doesn't need an X-ray, it doesn't need a CT, it doesn't need an MRI. It's really the physical exam. So what you feel are the cords and finger motion will become limited. So there are 3 phases of Dupuytren's. There's the first phase, which is where it first starts happening and you start getting the nodule formation. As that progresses, then you have these nodules and the cords getting thicker, and then you have more, like molecularly, you have more of the type 3 collagen being formed. And then finally, the type 3 collagen is replaced with type 1 collagen, which is more like scar cartilage. But on exam, this is what you see. So you see these pits and nodules forming in the palm itself. And then you can also see these cords. that happen, and it literally looks like a rope or a tendon almost underneath the skin, and that's what pulls the finger down. Some people will also develop these nodules over their dorsal PIP joints. They're called Garrod nodules, but they're just these fibrotic nodules that are there. And then as the disease progresses, then you get what we call the positive tabletop test. And the finger's bent down such that you can't lay it flat on a table. So most people will complain that it interferes with their ability to shake hands or also wash their face. Most men don't complain about golf, though, because you can still grip a golf club. So never interferes with your ability to make a fist, so they can always make a fist. It's really just that they can't flatten the hand all the way out. So once you have it diagnosed, how do you treat it? So the treatment options are listed here. So for early disease, there's radiation treatment. As it progresses, there's more invasive treatments, such as the needle aponeurotomy, Xiaflex injections, or surgical excision. So I'm going to talk a little bit about each one of those. For radiation therapy, this is really for when the hand hasn't started bending down. So it's when you first notice the nodules in the palm, and what the radiation oncologist can do is do these low-level radiation treatments, and the thought is that it softens the nodules and slows the progression of the disease. So for a lot of these patients that have the nodules but no contracture, I'll refer them over to Dr. Kennedy, a radiation oncologist at the hospital. As it progresses, so once you start getting the positive tabletop test, then we look at more invasive options. So one is what we call a needle aponeurotomy. So this is an office procedure. And so what happens is you take basically a hypodermic needle, and that beveled tip, you use it as a knife, and you try to cut through the cord. So, let's see. So here's kind of the cord that's there, and you really just kind of slice it. So imagine the cord's like a rope, and so that needle, you just cut the rope, and you break the rope so that the finger can lay flatter. So that's one of the options. Another office treatment is Xiaflex. So this is a collagenase. So it's an enzyme that dissolves part of that cord. It's from Clostridium histolyticum. It was FDA approved in 2010, but it's a 2-day procedure that happens in the office. So the first day involves an injection into the cord itself. So again, it's like a rope that's there. So imagine that the collagenase is like dripping acid on the middle of the rope, and then you let it soak in, and the next day you break the rope. So the rope is still there, it's just broken so you can lay it flat. So here you can kind of see the second day, they come in, you numb up the area, and you can kind of see it pop there. So it's so great when it happens. But it's, the finger lays flat, but the Dupuytrens you can see is still there. So it'd be great if it went through and just dissolved to everything, but it doesn't. So this is just on a loop. But you can see that they put gauze over the area, and that's actually because when you straighten the finger out, you can also tear the skin. Because imagine that the skin's also contracted. So when you stretch it out, the skin can also tear. And that's the biggest complication with these. So complications kind of are listed here. So swelling, ecchymosis, pain typically always happens, and that happens overnight that first night. And it's basically your body reacting against this enzyme. So you will get swelling, you will get bruising, and I tell patients that all the time. Pain you'll have in the area of the injection, and then some people actually report pain up in their armpit, and that's mostly because your lymph nodes are trying to clear out this enzyme. Skin tears is shown here. It's kind of shocking when it first happens. So you can see in these pictures the first time, it's this big open gash, and we don't actually close it, and it heals on its own by secondary intent. So if you can kind of follow the pictures, after a month, it's healed over and the finger is pretty straight. So it's just kind of local wound care that we do for that. The most devastating complication, though, would be a flexor tendon rupture. So the collagenase is not specific to Dupuytren's. It will eat through any collagen that you put in front of it. So if you inject the XIAFLEX too deep, you can dissolve the flexor tendon, and then it can rupture. So it's really important to know how to do the procedure well. Future therapies for it are really directed against the myofibroblast or fibrosis that happens with the Dupuytrens. The problem with finding a new drug is that there's no great animal model, and it's hard to find the efficacy of it. And the other thing is that there's nothing specific for the Dupuytrens. So we're left with that for now. And another option is surgical excision. So this is, it seems kind of barbaric, but big incisions down the palm into the finger. So there are zigzag incisions because we don't cross a crease straight through because it causes a different type of contracture. So big zigzag incisions down the palm. And what we do is we try to take out as much of that Dupuytren's as possible and then get the hand to kind of flatten out. So this surgery is great because you know what you're going to get from it right there in surgery. The problem is it's pretty invasive, and it does take a long time to recover and does involve a lot of therapy. So in a comparison of these different treatments, the needle aponeurotomy does have a high recurrence rate, but it is the least invasive. Personally, I'm not a huge fan of this procedure, mostly because it's a blind procedure. So you put a sharp instrument in the skin, wiggle it around, and you don't really know what you're cutting there. But it is the least invasive. The XIAFLEX has a little less of a slower recurrence rate, but again, you get the bruising, the swelling, the possible skin tears, and it's very expensive as well. Finally, with surgery, it is very invasive, and it's a long recovery, but it does have the slowest recurrence rate. So, take-home points. 1, Dupuytren's, what is it? It's a painless contracture of the fascia within the hand itself. It can cause the fingers to kind of slowly, permanently bend down. So the diagnosis is with physical exam, and treatment options kind of are what we listed before: radiation, needle aponeurotomy, XIAFLEX, and surgical excision. So I always try to give a little PSA. So Halloween's coming, carving tips. So bunch of tips listed here. The main ones to remember are, it's safer to use the pumpkin carving kits that they sell, like the serrated knives that are in there. And also, if you're cutting, cut away so that you don't cut any tendons or neurovascular structures in your hand. But if you do, I'm here to help you. So this is my information, my email, my phone. My secretary is Erin DeGrenier, and her extension is listed here, and my medical assistant is Lisa Johnson with her extension listed here. So thank you so much for your attendance and coming.